Welcome to the Health 210 podcast. Today we have with us a leading expert in pulmonary medicine and interventional pulmonology. He is a physician at the forefront treating complex lung diseases with advanced and minimally invasive procedures. Please welcome Dr. Abedi.
Happy to be here.
Thank you, Ali. Thank you for taking our time and doing this for us. If you could initially start off with, going back towards your background as to, where you grew up and how you got into medicine, so people get to know you a little bit more.
Yeah, of course. So I was born in Iran, moved to the United States when I was a teenager with my family. Primarily lived in Texas, went to school, college, grad school here in Texas.
Cool.
My family had some background in healthcare. In my immediate family, we didn't actually have any doctors. But I was encouraged, to start looking at healthcare as a possibility. And then I actually, when I was in college, is when I started to think about doing medicine, and I started volunteering at some local hospitals in Austin where I live. And until that point, honestly, I wasn't all that serious about it. But then once I saw what clinical practice looked like and how doctors and nurses could really make impact in people's lives, that's kind of what really got me interested. And so at the time, I had started on a research track. After college, I went into grad school and I was kind of working through a master's track and looking towards doing PhD biology research. And then after I started spending more time in the hospital setting, I got really interested, and that's when I switched tracks and ended up going to med school. And that eventually brought me back to Texas and San Antonio for residency and fellowship.
Yeah.
So I did all of my training here in town at the University Health System. And after that, eventually I met some local doctors at Methodist.
Mm-hmm.
Those are my partners now, 10 years later.
Yeah.
And so following med school, all of my training and then all of my clinical practice and everything I've learned and done on the job since then has been here in San Antonio.
San Antonio, cool, very good. So was it similar to similar cultures, right? I mean, was it like parents want you to be just like a doctor or an engineer? Was that a push from family or?
It was. My dad actually. So he's a pharmacist. My mom also a pharmacist.
Okay.
So he pushed very hard, and to be honest, that probably is what got me away from pursuing medicine to begin with, and getting into biology research and so on, because it was a lot. Getting pushed in that direction, and then fortunately, once I started to have that experience in the clinical setting, when I started volunteering in the hospitals, that sort of brought me back because I started to get interested in it myself.
That sounds good. And then, while doing your residency, was there something pivotal that kind of attracted you towards pulmonary medicine and, eventually interventional pulmonology, or how did that come about?
Yeah, I think for almost everyone who gets into pulmonary or critical care, it starts in med school and residency in the ICU.
Mm-hmm.
That's what attracts everybody because that's the first thing you see.
Yeah.
Pulmonology itself, as you know, in medical school and even in internal medicine residency, it's not something that's really pushed a lot.
Yeah, or not subspecialty. Also not too exciting, right?
Correct. Yeah. So you get excited about the ICU. You get to see the acuity, the level of complexity of patient illness, and then as a result of that, you get to see how you can make really significant immediate impact in patient outcomes by being in the ICU setting. So all of us really get into it that way. And then as you start going down that path in senior residency electives, and then once you start fellowship at the beginning, that's when almost all of us start to learn that pulmonology is actually really, really interesting.
Yeah.
You think about the lungs, the scope of pathology is so wide. Any category of illness, infectious, inflammatory, autoimmune, congenital, exposure-related, you have a wide berth of that just within the lungs.
Yeah.
And that's, I think, the reason that pulmonology itself over the years is starting to split into more and more defined subspecialties within that specialty. Sleep medicine and transplant
Are different
pulmonology,
categories,
correct.
yeah.
And interventional pulmonology along that path
Yeah.
is more and more kind of separating into its own specialty. And so what eventually got me more interested in interventional pulmonology is that as I started to do my fellowship at UT Health, there was a pretty robust interventional pulmonary program that was kind of combined with the lung transplantation program there. The same physician managed both
Yeah.
service lines, and at the time there wasn't a ACGME fellowship there. There was
Dedicated,
actually
yeah.
very few dedicated IP fellowships,
Yeah.
even 10 years ago.
Okay. And this is back 2015
About
era,
2015,
right? Yeah,
yeah.
that's when I was a resident and you were the fellow
Yeah,
at
yeah.
UT.
So
Yeah.
2013 to 2015, 2016 is when I did my fellowship. And
Yeah.
so because there was not a requirement to have a standalone fourth year of IP training to sit for IP boards,
Board,
there were relatively few dedicated IP fellowships throughout the country, and you
I
have
see,
to
yeah.
go there. That changed around 2016 when it became a requirement to do a full fourth year if you wanted to be a board certified IP.
IP,
And so
yeah.
a lot of new programs developed since then.
Since
around
then,
So
cool.
pretty much all academic pulmonary fellowships now will have an IP program, and that's actually something we're hoping to work towards here as we grow our GME programs
Yeah.
in Methodist.
In
Healthcare.
Methodist, yeah, perfect. So currently, scope of practice. So pulmonary doctors, work kind of split in between hospital and clinics. There's some ICU and clinic time. How does your practice look like currently, and what is it that you like to focus on?
My main focus, obviously, in terms of pulmonology, is interventional pulmonary, and that creates alignment with developing expertise and management skill in all the disease processes that would bring you to the type of procedures that interventional pulmonologists do. I still do general pulmonary because it's necessary to be a good IP. You have to be a good pulmonologist. To be a good pulmonologist, you have to be a good medicine doctor.
Yeah.
And I still do critical care, one, because I truly enjoy it. It's what brought me to pulmonary and critical care. I still spend half my time in the ICU. And also because for our specialty in the private practice setting, for the most part, you need to have a mix of how you spend your time and how you make your reimbursements.
Yeah.
And so my time is 50-50 when I'm in the hospital, in addition to doing ICU, I do see inpatient pulmonary consultations, and in that sense, I try to keep my focus mostly on IP and lung cancer related issues.
Okay.
And in clinic, in addition to doing general pulmonology, because again, there's a lot more of that than there is IP related issues, I do very much try to focus on lung cancer management and then other non-malignancy related IP pathologies and management. Yeah.
And then if you break it down for the audience a little bit more, when we talk about IP or interventional pulmonology, we're basically talking about a bronchoscope, right, or bronchoscopy and associated procedures. So if you can elaborate a little bit as to what are the common procedures that you do and what it actually looks like.
Yeah, so interventional pulmonology, you can think of it as a subspecialty of pulmonology that is focused on doing what I would call advanced bronchoscopic procedures and pleuroscopic or thoracoscopic procedures. And beyond that, it's developing or having expertise in the management of those types of pathologies that are associated with those procedures.
Yeah.
Procedural skill certainly is a big part of it, but like surgeons, doing the surgery is one thing. Knowing how to manage before the patient before surgery
and after,
what kind of surgery or whether to do surgery and after, that's really where the expertise is in the management of those conditions. So advanced bronchoscopy, we consider it things like airway interventions, complex procedures where we're performing interventions in the trachea and bronchial tree, as well as navigational bronchoscopies where using various different technologies, we can try to get to specific locations in the periphery of the lung and be able to do biopsies, as well as mediastinal biopsies of lymph nodes and things of that nature. Then dealing with pleural disease, And so interventional pulmonology includes everything from chest tube insertions to managing recurrent pleural effusions, and even doing sort of mini VATS procedures where we do single port thoracoscopic assessments of the pleural space, where we can again biopsy, management of pleural effusions, pleurodesis, indwelling pleural catheters, and so on.
A lot of things that would need like more open or invasive surgeries back in the day are kind of managed with minimally invasive procedures through this.
Correct. Yeah. Technology advances, and so we've always the sort of playground of interventional pulmonology has always been endobronchial and endotracheal procedures that can affect. Most of the time, we're talking about blockages in the airways from benign or malignant processes. That still is sort of the bread and butter of what you would consider sort of advanced airway intervention. But more and more diagnostic procedures that used to require transthoracic approaches with needle biopsies going through the chest can now be done with advanced diagnostic tools bronchoscopically.
Through the airway.
Lung volume reduction, for example, for patients with emphysema, that initially was a surgical process where emphysematous portions of the upper lungs would be removed by a surgeon. That can now be performed by doing endobronchial valve insertions, where we essentially block airflow to diseased parts of the lung.
So it's almost like you go and put a valve and shut off that part of the lung.
And that's exactly what it's called. It's called endobronchial valve insertion to essentially block parts of the lung.
Because that part of the lung is not really serving the purpose, and it's basically wasting air and effort. So might as well shut it down.
Yeah, it reduces tension of air in the chest, so it's easier to move the lungs and breathe, and it shunts the work of breathing to healthier parts of the lung.
Perfect.
And then again, the pleural space, so that's the space inside the chest that's not occupied by the lung, that normally is a potential space. It's just a film of liquid there. Certain disease processes can obviously create collection of fluid and tumor, and so on. And so interventional pulmonology also deals with those kind of issues. And all of this obviously is in collaboration with our surgical colleagues, cardiothoracic surgery and ear, nose, and throat surgeons. Because one of the important things when you're doing advanced procedures like this is that everybody needs to know the limits of what you should be doing. And you need to reach out for
and when you need like something invasive. Perfect. So we've touched a little bit about it, but a major one of the most important topics is lung cancer, right? And so lung cancer has been a major reason for mortality for a long time. Smoking, which is considered one of the biggest risk factors, there has been a change in trend over the last few decades. It's kind of fallen out of being this cool hip thing to kind of being put to side in most social settings now. What are you seeing being an expert in this field? How are the lung cancer numbers looking, and is the reduction in smoking helping, or where do we see this going?
So I'll reiterate what you said. Lung cancer is a huge problem when it comes to cancer-related mortality. So for men and women both, lung cancer is the third most common cancer. It's behind breast and so on for women, and then prostate and colon. But it is the number one cause of cancer-related death for everybody. Men, women in the United States and worldwide. And the reason for that is that we almost always tend to find it in later stages when we look at overall numbers. Those trends are getting better, but it's a disease that typically would present in late stage because it's an asymptomatic disease until the mass is large enough to cause local compression, which means it's had a lot of time to grow and spread, or based on symptoms from metastatic sites. Those trends haven't necessarily changed in the sense that lung cancer is still very deadly. We are seeing slight declines in the rates of incidence because people are smoking less, but it's still a very common cancer, and again, the most common cause of cancer-related death. Now, in terms of the causes, like you said, the most significant risk for developing lung cancer is smoking. Smokers have a 20 times higher risk of developing lung cancer than non-smokers, even though about 20% of lung cancers happen in non-smokers.
Non-smokers, yeah.
But smoking dramatically increases your risk. And so, because of a lot of factors, the public and the medical and scientific community have all become a lot more aware of the dangers of smoking over the last 5 decades. And there's been concerted efforts both from the medical community, but also government intervention and a lot of marketing to try to get people to quit. So the rates of smoking have significantly dropped over 50 years, going back to the 1960s until within the last 10 years when the data is available for. The rates overall for smoking have dropped from about 40% of Americans down to about 10 to 13.
Yeah.
So that's a significant drop.
Yeah.
The interesting thing there is that the rates between men and women have sort of evened out.
I see.
Because there hasn't been a significant change in the number of women smoking. That's been about 10% and stayed about 10%.
10%.
But overall, in the United States for adults, it's about 10 to 13%.
I see.
And lower still, even more significant drops when it comes to youth groups.
Mm-hmm.
Right? So younger than 18, we have even more steep drops in the rates of smoking. We still see a lot of lung cancer because there's going to be a 10 to 30 year lag.
Yeah, before we see
risk.
Yep.
Right.
Yeah.
So we still see a lot of patients coming in. But again.
So from a lung cancer perspective, given that it's such a major reason for mortality, someone who does not smoke, I know every person is different, family history, genetics, they all play a role. But for a relatively healthy person, is there any sort of screening guideline or anything that they need to worry about or they can do with their primary care doctors to, you mentioned there's like a 20% population that gets lung cancer, even for non-smokers. Is there anything that those people can do or should worry about?
There isn't any formal requirement or recommendation for lung cancer screening for people who are not in a high-risk category, which primarily is heavy smokers, recent heavy smokers. The reason for that is that, and this was all looked at in large-scale studies that came out in the U.S. Special Task Force for screening findings over 10 years ago now. This was the big landmark paper in the New England Journal. What was determined is that for the general public it doesn't make sense because it'll drive a lot of unnecessary biopsy procedures. One of the important things, and this is a conversation I have with my patients when they come into the clinic with a finding of a lung nodule. And for any of the audience who are not in medicine, a lung nodule, when we say that, we're basically referring to a specific location in the lungs where the normally delicate sponge-like lung tissue that's full of air starts to turn more dense and become solid, kind of like your muscle. So it stands out on imaging. So when we find nodules, either because it was incidentally found on imaging that was obtained, or even in the case of CT scans that are done specifically for the purpose of screening meaning these are high-risk patients, smokers, the highest risk category. Of all those nodules we find on screening CT scans for lung cancer, about 4% end up being cancer. The rest of them are scars, remnants of previous infections, and things of that nature.
Or just normal evolution of tissue that wouldn't do anything, right?
The lungs will scar like any other part of the body when there's an injury. And so if you applied that to the general public, you would get a lot of findings that potentially would end up as biopsies that would be benign, and so you would be too many unnecessary biopsies.
And then the cost-benefit ratio also kind of laying tips.
And complications of those procedures. Now, for those people who are smokers, though, it is a dramatic improvement in mortality related to lung cancer if you're doing regular screening. I like to use the example of beta blockers in cardiology. So if you work in a hospital setting and you work in a critical care, especially a cardiac critical care setting, you know that when patients come in with heart attacks or cardiac surgery, we have literal clipboards that we use to make sure that they're on their beta blocker after surgery.
There's a checklist when you discharge them. They have to be on certain medications.
They have to be on those medications, and so for beta blockers, the impact we're making in mortality is it's fractions, right, of percentages.
Correct.
If you have people who meet criteria for lung cancer screening, so these are patients who are between 50 and 80 years old. They have a 15 pack year, so the equivalent of a pack a day for at least 15 years of smoking history, and that's active or they quit within the last 15 years. For those patients, if you're doing yearly low-dose CT scans for screening, you can reduce their likelihood of mortality due to lung cancer by 20%. I mean, it is, you don't see anything like that anywhere in medicine. And so that would make you think, this is a triumph of medical science. We're going to save so many lives. And then you look at the number of people in the United States that qualify for lung cancer screening, and the number that we actually screen is about 2 to maybe 5%.
It's pretty abysmal, right? Yeah.
That's our main issue, is that we have a very, very effective intervention for reducing lung cancer mortality, and that's screening, because the name of the game when it comes to improving survival in lung cancer is stage shifting. Shift the majority of the diagnoses that come at stage 3 or later
to earlier
over to stage 1, where you can cure with surgery or radiation.
And the screening modality would be a low-dose CT, correct?
Yeah, so a yearly or every other year CT scan. It's not a full-dose CT scan, so again, the level of radiation is considered in that. And findings that come up, then you go to a specialist, a pulmonologist, oncologist, interventional pulmonologist, who then can help you go through the process of determining if this is a significantly risky finding based on your particular risk factors and what that nodule looks like, and how it may behave on functional imaging like a PET scan. So does it need a biopsy when you find it, or is it something less concerning where you can just forget about it in rare cases, or the majority fall in this gray zone where you decide at some point within the next, say, 3 to 12 months, you need a repeat CT scan to figure out if this thing is still there, growing or not.
If it's changing or not, and concerning for cancer. So some important stuff that you mentioned there. So pack years of smoking, right? So it could be like, some people don't smoke like 1 pack a day. They smoke half pack a day. So they can calculate their number of pack years based on that. So let's say you smoke like half pack for 10 years, so you're like 5 pack years.
5 pack years.
Right. And then the other important number you mentioned there is 15 years out from once you quit. So is that roughly the timeline where their cancer risk kind of goes down to similar to a non-smoker?
General population. The thought process there is that a cancer that's related to that person's smoking exposure should have developed within that 15-year window. And if they've passed it, their risk should be the same as the general population, and so it doesn't necessarily make sense. And then in terms of the age categories, less than 50 years old, and some of these were changed recently. It used to be 55 to 75, so we've expanded it to catch more people in both directions.
Sides,
but younger than 50, the length of time of exposure of smoking probably is not enough to warrant it. And above 80, then you start to think about the increasing risk of biopsies and cancer treatments for a patient category that life expectancy, even without cancer diagnosis and treatment, it gets shorter and shorter as you get beyond 80 years old.
So the important message is, if you're 50 and older and you smoke like 15 pack years or more, then you should be getting a yearly lung cancer screening with a low-dose CT scan, right?
Absolutely. It'll reduce your likelihood of dying from lung cancer by 20%.
That's a huge number.
Absolutely.
I kind of feel like it's not talked about as much. What's your take on that? I mean, we tend to hear a lot more about like colonoscopies, which is another major, and breast cancer. But
the reasoning for it is, I think,
like I have to remind patients, hey, did you smoke? You should probably get a CT scan. But they kind of already know about like mammograms and colonoscopies when they come for like primary care checkups.
A lot of it is, some of it is the way it's marketed. Breast cancer is a great example of how you take a disease and use, the social aspects of it being a women's disease to create like an empowerment sort of approach when it comes to screening and management. Colonoscopy is one of those things where everybody has a colon, and the colon cancer is something that happens to us, and it's something we need to do. The problem with smoking is that there is this sort of misconception that when somebody develops lung cancer, it's because they did it to themselves. And it's difficult for patients and also for clinicians, doctors, nurse practitioners, counselors, to separate that conversation of smoking from the conversation about lung cancer
Yeah.
screening. And it's a tough conversation to have. People who are sort of committed to being smokers at that age, they've been through it many, many times,
Yeah.
and those conversations can be, sometimes you feel like you're browbeating the
Yeah.
patient and they feel like they don't want to talk about
Yeah.
it. But it's important because, again, even if we go through all of the counseling steps and everything to try
To help
get
them
somebody
like
to
stop
quit
smoking, yeah.
for a variety of health reasons, even if we can't get there, it's still something we can help by getting them to go through lung cancer.
Prevent it or catch it
One
early. Yeah.
particular severe complication of
Yeah.
smoking, we can maybe do
Yeah.
something about.
That's an interesting point, because I think that's an important aspect to think about from a provider standpoint, that you don't let that that biasness or that sort of partiality come into it, where you don't go from like, oh, you don't stop smoking or prevent it, but you should still have a very clear goal towards preventing lung cancer, or at least catching it, so they can have a better future.
So from my perspective, I look at the discussion about tobacco use and tobacco cessation as opening the door to talking about lung cancer screening.
Yeah.
Right. You have to bring it up so you can talk about lung cancer screening. And the other thing is making sure that there's resources available, and our clinicians, our primary care doctors primarily, and their staff are aware of the resources that we have in the community, because on the part of providers, and there's surveys obviously that look at all the reasons why adherence to lung cancer screening is so low. In addition to the difficulties around the discussion with smoking, there's the issue that a lot of primary care providers, based on those surveys, it seemed as though they had concerns about all the stuff you're going to find when you start doing these CT scans, and it's so difficult for me to get patients in to see specialists, oncologists, pulmonologists, and that becomes a barrier sometimes, because what are you going to do with all these findings when they start popping up? And so making sure that we're doing a good job setting up resources and also communicating those resources to the medical community, so that we have a think of it as an easy button setup to where all you got to do is order a CT scan. One of the things that we've been working on in our company and in collaboration with our health system is trying to create a all-in-one smoking-related suite of services where you have a patient who's a smoker, just send them to us. We'd love to talk to them about smoking cessation. We'd love to offer them resources that we have in the health system for smoking cessation, counseling, and so on, drug therapy. And at that time, we'll open the door for the conversation about lung cancer screening. And if findings come up, then they're already in the hands of the specialist who's going to manage those nodules up to the point of biopsy. And if the biopsy reveals a lung cancer, they're still, again, checked into the pathway for lung cancer navigation, which is a very robust and well-organized system that we have set up.
So they're already in the right place from the get-go, trying to cut down on the addiction issue and help with that, and getting the best resources, right? Because they're with the specialist, and then if something comes up, they're in the right hands to deal with the complications.
Of course.
So let's say someone does get a diagnosis of lung cancer and it's early. With interventional pulmonology, what procedures can you do? Is it just a simple fix as a bronchoscopy where they get the nodule taken out and that's it? Or how does it look?
So the role for interventional pulmonology right now when it comes to early stage lung cancer primarily is in detection. We do diagnostic procedures, more and more doing navigational bronchoscopy, specifically with robotic catheter navigational bronchoscopy systems that have been on the market for about 6 years now. It's more and more becoming accepted as a viable alternative to doing transthoracic needle biopsies of the lung, with several benefits as compared to transthoracic needle biopsies, some of them being lower rates of complications when it comes to the primary complication of both bronchoscopic and transthoracic needle biopsy is lung collapse or pneumothorax. It's a lot less likely for that to happen when we do bronchoscopic biopsies. But we also have the ability to biopsy multiple nodules in the lung
in the same procedure,
when we do bronchoscopic. And more importantly, because we're already doing a bronchoscopy, the patient's in the OR, under anesthesia, we're able to add mediastinal bronchoscopic staging, and this is a procedure that happens with a different flexible bronchoscope, so a flexible camera tube that has an ultrasound probe, and we can go along the path of the trachea, the windpipe, and the bilateral main bronchial airway ways. In any enlarged lymph nodes that we see, we can sample them at the same time to make sure that we have both diagnostic and staging information, and then we hand the patients off to the surgeon. When you do this within a organized lung cancer program setup like we have in our health system at Methodist and with collaboration with my group, everything from prior to deciding on a biopsy to doing the biopsy and then getting the patient to definitive treatment is streamlined, efficient, goes through navigation by dedicated nurse navigators and multidisciplinary, multi-specialty planning through tumor boards and discussions that is cooked into the process. And doing it efficiently like that can cut down what currently is the national average for detection of a nodule to surgical removal for early stage lung cancer at 3 months.
3 months.
We can cut that down to anywhere from, say, 8 to 12 weeks. From anywhere from 4 to 6 weeks, which is half.
Yeah, right? Almost half, yes.
And that's important because during 3 months, somebody can go from what you thought was an early stage lung cancer to microscopic metastatic disease that then comes back.
That could be progression. Plus, I mean, that phase is like the worst for from an anxiety standpoint for a patient. Once they know that there is something that has a suspicion of being cancer,
it's torture.
They have sleepless nights and, they just can't wait to get to the next step and get answers.
Yeah. So one of the benefits, again, of having interventional pulmonologists, in my mind, who can provide this type of a biopsy route is that instead of what used to be or has always been the routine, which is detection of a nodule, somehow the word gets back to the primary care provider, who then has to figure out how to do a biopsy.
Yeah.
Maybe you do a referral to an oncologist. Well, now the 2 weeks that took to get him in your office is now maybe 5 weeks to see the oncologist. Now the oncologist orders a transthoracic biopsy by a radiologist. There's another 3 weeks, and then after that, back to the primary, and then to a surgeon. There's another 3 weeks. That's how you get the 3 months.
Yeah.
Whereas if you put your lung cancer specialists, whether that's going to be your IPs or your oncologists in your lung cancer program, because we have the ability to take the nodule detection and do everything from there ourselves, now you check the patient into a dedicated, navigated, streamlined process of detection, diagnosis, treatment planning, and delivery to the hands of the doctor who's going to do the treatment in a much shorter time frame.
Yeah.
And that's the benefit of it, I think, more than anything else, even more than reducing complications from the procedure and so on, is that you're handing the patient off from the top of that pyramid to the specialist who's going to move them through
the line. Yeah. And one of the major reasons for this whole podcast or showcasing all the specialists that we have here in the San Antonio medical landscape is to we see patients mutually a lot of times, and if I see someone that I really wish I could get them to your clinic ASAP. We have very streamlined communication where I can just, reach out to you and that happens very quickly. But you were telling me about that internally in your group as well, you all have a very robust system of triaging patients, right? Like, let's say me as a primary care provider sends a patient over to your practice. Tell us about that as to, how patients are streamlined so that they get the right care as soon as possible.
Yeah, so my company that I work with, I'm a partner of, is Texas IPS. We're a large pulmonology group here in San Antonio, and we interact with Methodist Healthcare. We do a lot of our patient care at Methodist facilities. And so our group has grown large enough over the years where it's allowed us for the physicians in the group on the pulmonology side to start focusing a little bit more on their areas of interest. And so naturally, subspecialty service lines within our practice have developed. And so it's a scenario where what we like to do is get the problem to the patient who has the expertise in managing that problem.
Yeah.
And so we all practice general pulmonology, but some of us who have certain interests that we've worked very hard to develop expertise and support services around also have the ability to take referrals that come in for one specific sort of complex problem, and without necessarily having to do re-referrals to other specialists within the group from the very beginning, we make sure that it's the correct doctor or doctors that are taking care of that particular problem for that patient. And that happens at the time that referrals come into the office. And so this way we know that we're providing sort of the best guideline supported, state of the art.
In a timely manner. So anyone with a lung nodule or lung mass or stuff like that is going to your specialist like yourself and your IP group to kind of, get the ball rolling as soon as possible and get them on the right track.
Absolutely. And we have the same mechanisms in place for sleep medicine, for interstitial lung disease or scarring types of lung diseases, for pulmonary hypertension, which is a disease with elevation of blood pressure in the lungs. And we're also working on developing subspecialty service lines within our practice for complex asthma diagnoses and lung transplantation evaluations and so on.
Perfect, cool. All right, Dr. Abedi, so we'll change the pace a little bit. So quick segment, we call this, myth or fact. So I'll read out some statements and then you tell us whether, this is something real or just a myth. Okay. So if you can run a marathon, you probably have healthy lungs.
That is... I would say that's a fact.
That's a fact.
Cool. You can have lung disease, asthma, COPD even, but if you don't have well managed chronic lung disease, it's going to be difficult to run a marathon.
Okay, cool. Asthma is only a childhood illness. You'll grow out of it.
That is absolutely a myth.
Okay.
I have a lot of adult asthma patients who would be surprised to hear
that. Holding your breath for a long time means you have strong lungs.
Not necessarily, no. That's a myth. That just means that you have trained yourself to be able to hold your breath for a long time.
So you can function at those low oxygen levels and not pass out. Vaping is safer than smoking.
That is, I'm going to say myth because it's not necessarily safe. We don't have a lot of information on vaping at this point. It has presumably lower rates of lung cancer associated with it, but it comes with its own host of
issues, right? A lot of chemicals and stuff. And primarily because you're not exposed to smoke and then tobacco, correct? Is why probably lower risk.
Yeah, but like you said, the problem with vaping is that there's really no telling what compounds are mixed into some of these commercial preparations. Everybody remembers the big outbreak of the vaping-related lung injury.
The popcorn lung that was famous.
And that was because one particular brand was using vitamin E acetate that was causing ARDS or severe acute lung injury. But popcorn lung is actually associated with much more commonly used compounds that a lot of vaping solutions have, and it's something that happens to some people. And
there's no way to know who will get it, right?
Correct. And there's no way to know what's in the compounds that you're buying. And so that's part of the issue,
If you don't cough, your lungs must be fine.
That is a myth. There's a lot of different kinds of lung disease you could have that doesn't necessarily have coughing associated
won't make you
with
cough.
Like we said, early stage lung cancer is asymptomatic. There's no cough. There's no way to know unless you look for it.
Living in Texas, cedar season builds character and lung strength.
It does neither of those. That is a myth.
And lung exercise can replace going to the gym.
I would say no. There's not a lot of what I would consider specific lung exercise. There are ways of improving your breathing technique during exercise, and we do that for patients who have lung disease in programs called pulmonary rehabilitation, where in addition to doing aerobic exercise and weight training exercise, we also help with some
rehab
techniques and so on. But doing physical exercise, whether it's resistance training or aerobic training, is actually a very good way to maximize what you can get out of whatever lung function you have.
So optimize that, And then last one is oxygen bars are the future of wellness.
I would have to say again that's a myth.
They're getting very, very popular though.
They are
certain
very
cities.
Popular. If you don't have low oxygen numbers that are at a level that cause significant symptoms when it comes to your brain noticing that the oxygen levels are low and telling you that you're short of breath and breathe faster, or at a level that puts strain on your cardiovascular system and so on, there's no benefit to using
extra oxygen. Cool. All right. Cool, perfect. All right, Dr. Betty. So coming to research and education, I know you're very closely involved with the Texas, the San Antonio Advanced Lung Symposium that happens here in San Antonio. Could you tell us a little bit about that conference?
Yeah, it's an idea that came up about 6 years ago now. We realized that because of a lot of hard work from the clinicians and the staff, both from our group and the health system that we interact with at Methodist, we had developed a lot of robust pulmonary subspecialty programs that were doing a lot of good for our patients in the community, and we wanted an opportunity to be able to sort of do a show and tell and tell our physician partners in the community from various specialties that we have these services available in Methodist, and also try to be a little bit more involved in academics and being able to provide educational opportunities for pulmonologists in the community. And so we created a symposium that's primarily focused on management of various types of lung disease. We started it in November of 2019 was the first.
Okay.
And we actually managed to keep it going through the next few years with the COVID outbreaks.
Spike, oh yeah.
And so every November, on the second Saturday of every November, we have a one-day symposium that typically is at La Cantera Resort at their conference center. And we try to do a mix of local speakers who can provide information about our pulmonary services that we provide through our practices in the Methodist health system, in addition to usually bring in one or two outside speakers who are people who are at the forefront of developing the science that's going to take these specialties into the future, and giving our audience a little bit of a primer on expert opinions and new things to come.
So definitely a major event in the San Antonio medical landscape, right? Where I mean, as far as pulmonology and interventional pulmonary medicine goes, definitely a must attend for people interested to kind of enhance their knowledge and see what's happening.
Absolutely, and we try to keep it focused on pulmonology. There's usually a little bit of critical care issues mixed in there, but we try to have one topic. Usually we have 6 speakers. We try to have one topic from every major category of pulmonary disease for the audience.
And then you personally, and then your group as a whole, along with the Methodist system, what are the plans in the future on the GME side? Because we know there's a lot of evolution happening on the GME side as far as residency and fellowship programs go. What do you see on the pulmonary front?
There's been a lot of focus at Methodist Healthcare for trying to participate and help improve graduate medical education to help with the shortages of physicians, and that's been plaguing the healthcare system for the last decade or more. And so internal medicine residency was one of the programs that was started in the last few years. And we certainly, as you said, we're involved in it along with a lot of our other colleagues from different specialties in the health system. And for us, again, having already developed a lot of fairly complex and well-organized subspecialty clinics and service lines within pulmonology and critical care, it's kind of a natural progression to think about the possibility of adding pulmonary and critical care fellowships.
Yeah.
And then obviously something that's a passion of mine is eventually considering whether we can serve as a location for training other interventional pulmonologists.
An IP program as well.
Because that also is an area of great need, especially with the burden of lung cancer like we talked about.
And we definitely have the clinical, like Methodist healthcare system with, the amount of patients and the footprint. We definitely have the ingredients to set up something like that.
Absolutely, yeah. And again, we would love to help and participate, and it's really rewarding to be involved in resident education and teaching the next generation of doctors who are going to hopefully figure things out that we still don't know currently. And that also brings us into considerations of clinical research. I like to think of our lung cancer program, for example, as being able to offer everything that a patient could get by going to some of these famous standalone cancer centers around the country.
Yeah.
The one area that we could do better is the opportunity to provide clinical trial enrollments. We have a lot of opportunity with our oncology partners around San Antonio at their practices. They all have really robust research programs.
Yeah.
Clinical device-related research is something that hopefully we can start to get more into. And so you asked me earlier, what's the role of the interventional pulmonologist in managing early-stage lung cancer? And I said it's mostly diagnostics. That's been the case. When it comes to intervention, we do have a lot of involvement in managing treatment of lung cancer, but it's almost entirely late-stage lung cancer.
Mm-hmm.
Patients who come in with locally invasive disease that's causing blockages of airways and collections of malignant fluid inside
Yeah.
the chest. And so really we're doing mechanical work at that point
Yeah.
to palliate the symptoms by reopening airways and trying to get them to a point where they can go home
Yeah.
and be comfortable, or maybe continue to get their cancer treatments. In the future, there may be opportunities for alternate therapies for early stage lung cancer for those patients that maybe are not good candidates for surgical resection. That might involve delivering treatment endobronchially at the same time that biopsies are done. That kind of research has been ongoing for decades, and it's been difficult because the lungs are really delicate organs that don't tolerate a lot of damage when it comes to delivering energy locally. But there's other technologies on the horizon where using lower energy levels delivered directly to the nodule through an endobronchial procedure, you could potentially induce immune reactions that might then prime the patient's immune system, and then be used with other therapies, systemic
to kind of fight the bad cancer cells.
And so that kind of research certainly is something that we would love to be involved with and help grow the edge of science in a field that's dealing, like we said, with the deadliest cancer.
Perfect.
That patients can face.
You touched upon this a little while back briefly. I want to do a little bit more in depth. So vaping is a big issue, right? And we're as primary care providers and just seeing and interacting with the community, we see it's being adapted very quickly and a lot more by the younger population. It's almost like the cigarette substitute, right? The same young adolescent kids, who would probably pick up smoking maybe a few decades back are kind of switching to or doing that for vaping. What are the common disease conditions you see, and what would you like to tell them or say to them as to what they're exposing their lungs to?
So it's a very important topic. When we were speaking earlier about smoking rates, and I mentioned that smoking rates have dropped significantly over the last 50 years. They've gone about 40% of Americans down to about 10 to 13%. And that decline was a lot better in the youth population. When it comes to vaping, it's the exact opposite. There's been certainly an increase in the rates of vaping. Over the last 10 years, the numbers have almost doubled. They've gone from 5 to 10% up to closer to 15 to 20% of people who vape. For youth populations, the overall numbers still aren't that high, but the rate of increase is kind of astronomical. It's like a 500% increase. It's gone from around 1% to maybe 5% in high school kids and so on. And the other important thing to note is that as you might expect, kids, adolescent and young adult, younger than 18 age category, who start vaping are much more likely to move on to smoking cigarettes in the future. And so that itself is an issue. Obviously there's physiologic disease processes where just the consumption of nicotine products is going to be a problem, cardiovascular disease and so on in the future. But when it comes to vaping itself, one thing we mentioned briefly is that, one, we don't have a lot of data. Even though these products have been around now for the last 10 or 20 years, because it's only been 10 or 20 years and the wide-scale use is really now developing, we don't have a lot of long-term data on what this stuff can do to your lungs. We do have a good volume of information already, despite that tells us it's not something you could really consider safe, even though it's not smoking cigarettes. Like we said, depending on what kind of additives may be put into products that are being made in more kind of local markets,
Yeah.
any kind of contaminant can get in, and that's what created that outbreak around 2019,
Yeah.
where some random compound that the people who were making that product had laying around, they put it in, and it turned out it was causing an acute lung injury. But all the other more commonly and sort of ubiquitously present additives in these compounds that create the flavoring and things like that that a lot of them have. Those are compounds that for some patients with prolonged use can create lung damage. So bronchiolitis obliterans is a process where the microscopic airways in the lungs start to get inflamed and basically destroyed.
Yeah.
That's the disease that was previously referred to as popcorn lung, because it's something that would happen to factory workers in popcorn factories. They were putting these hot, oily additives for flavoring on popcorn, and this stuff was being aerosolized, and they were breathing it
getting
in,
into their
and it was
lungs.
causing lung damage. And with vaping, you are actively inhaling similar compounds into your lungs. We also know that vaping can significantly increase the symptoms of asthma if you already have asthma. For some people who did not previously have asthma, or at least didn't have severe enough symptoms for it to be evident, they can develop asthma, and that's something that sometimes we call it reactive airways disease, which is something that happens as a result of an explosion and basically is sort of like asthmatic lung disease from there forward. There has been some evidence that development of COPD and emphysema has been seen with people who only have vaped, they never smoked cigarettes, and they still developed evidence of emphysema and then COPD. And then in some patients, consistently using vaping products for a few years, they can develop this process called formation of blebs in the lungs. And blebs are basically little blisters that form on the surface of the lungs, sort of like bubble wrap paper.
Okay.
And so what do people like to do with bubble wrap? You like to pop it.
Pop it.
So blebs, sometimes they spontaneously pop. And when that happens, air leaks out of the lung, and the lung collapses. That's pneumothorax, which we discussed earlier. And so when young people come in, this is a common enough thing that when young people come in with a spontaneous pneumothorax, so there's been no injury, there's been no procedure, they just come in with a collapsed lung, one of the first questions we ask is, do you vape? Because that's something that's
they would have blebs that predisposes them to that. Yeah, right. Okay, cool. I have a few quick questions for you as well. Again, like a quick round of rapid fire. So, if the lungs could talk, what's the first thing they'd say to their owner?
Treat me well.
Treat me well. Okay, that's good. Okay. What is tougher, getting through med school or convincing someone to quit smoking?
Getting through med school and then convincing someone to quit smoking.
That's funny. That's good. If you were stuck on a desert island, would you want to have your bronchoscope with you or your stethoscope?
I think I would want to have my bronchoscope.
Bronchoscope, yeah. You know, that's probably your third eye.
Use it to fish.
Yeah.
If I have a forceps, I can use it to fish.
Cool. Yeah. What's the most interesting object you've removed from an airway?
What I commonly remove from airways, the two most common things I remove from airways are thumbtacks and nails. Because what do you do when you're putting stuff up? You hold it in your mouth, and then you take a big breath, and it's down your lung. And then the second most common things are things that dentists drop down into your throat.
Oh, really?
And then, correct.
Okay.
So crowns, drill bits, things like that. Beyond that, bits of food, pills.
That would be an interesting call. A dentist, sending someone to the ER or calling a pulmonologist. Hey, I dropped something in my patient's.
Correct. Yeah, it happens.
It happens. I mean, it's a risk,
most of the time, it's swallowed, and you just wait for it to come out. But sometimes it goes down into the trachea, and it's immediately obvious because you're coughing and stuff.
If you could ban one thing for the lungs, would it be like smoking, vaping, or karaoke nights?
I would say smoking.
Smoking, okay, so it's definitely up there.
Because more people do it.
Yeah. If you weren't a pulmonologist, where do you think you would be?
I'd probably be a different kind of doctor.
Different kind of doctor. All right, interesting. Yeah. For people who would like to reach you or consult with you, where can they access what practice locations you have, or how can they reach you?
So as I said, I'm part of a local, large pulmonary and critical care group here in San Antonio. We're called Texas IPS, which stands for Intensivist Pulmonary and Sleep. So we manage patients in the intensive care unit, we manage all kinds of lung disease in the hospital and in the clinic setting, and then also sleep medicine. And so we have multiple offices here in San Antonio. We have an office in Bernie. We have our biggest office at the medical center on the campus of Methodist Hospital. We also have a clinic in Northeast San Antonio on the Northeast Methodist campus. And we are on our way to opening an office in Westover Hills and eventually
Perfect.
in downtown San Antonio. We have our number, so it's, I believe, 210-690-7400.
Okay.
But also, if you just put Texas IPS in your phone browser, the first thing that comes up is our website. You see the pictures of all the doctors and how to get a hold of our clinic.
Perfect.
And for our providers, clinicians, and physicians, nurse practitioners, same number.
Yeah.
And if any of you know us, you ever need to get a hold of us for something that's urgent, or you just want to make sure that your patient's getting in, you just pick up the phone and call us, and then we're happy.
And I have to say, you and pretty much all your colleagues, it's a very approachable group. Whenever you need help, everyone's like willing to step in and make sure that patients get the best care that they need. I really want to thank you for taking our time and being here. This was very insightful, especially your expertise in, invasive pulmonary medicine and then lung cancer. Provide a lot of useful information for our audience. So thank you for coming, and we'd love to do this again, talk about some other topics. Thank you again.
Thank you very much.
Cool. Thanks, man.